Okay,
Well, good evening.
good.
Good evening, everyone. My name is Kevin Britt, and I'm a board member with West Virginia Wellness. And it's my pleasure to welcome you tonight to the February 2022 Life Lecture Series featuring Andrea Hale from Valley Hospice. Valley Hospice is a nonprofit organization that serves people at the end of their life in both Ohio and West Virginia. I need to make a disclaimer before I continue, and that is that I do have a dog in this fight. I am currently the chairman of the board of Valley Hospice. So the individual presenting tonight is indeed a member of an organization that I am affiliated with. And I couldn't be more proud to be affiliated with this organization. But let me step back and say that for those who don't know, West Virginia Wellness has one goal and one goal only, and that is to educate people about how to improve the quality of their life through lifestyle decisions and healthcare decisions. Tonight, we are welcoming Andrea Hale, who is the Chief Operating Officer of Valley Hospice, who has an enormous base of experience in providing clinical care for people at the end of their life. She is a marketing guru, and she has incredible creativity in terms of bringing new programs and services to folks through Valley Hospice to serve them at the end of their life. What we know is that when we talk about improving the quality of life, there are stages of life. And tonight, Andrea is going to be speaking to providing quality of life for the end of life, people at the end of their life, with respect to services provided by hospice and palliative care. I couldn't be prouder and more excited to introduce to all of you, Andrea Hale. Andrea, give us your best.
Thank you, Kevin. Thank you so much. I'm going to share my screen now, and I was talking to Kevin before the presentation. Presenting virtually is something that we had to learn through COVID. We've gotten used to it, but it's still awkward because sometimes depending on the system, you're either just looking at yourself or one other person, or just the screen. So I'm going to see what Zoom does for us here and see if we can get this started. So do you see my screen that says Valley Hospice Caring? Great. And I can see all of you, so that's good. On the Teams version, you can't always see everybody. You can just see a couple of people. So thank you, Kevin, for that introduction. And tonight, we're going to talk about Valley Hospice Caring Connections Palliative Care Program. This is the logo and our tagline for Caring Connections Palliative Care. And Kevin teed that right up because your mission fits with our motto, the path to a better quality of life. So that's a perfect fit for tonight's discussion as our mantra for our palliative care program. I wanted to start out I'm going to move my little screen here, talking about Valley Hospice for a moment, because Valley Hospice, Caring Connections Palliative Care is a program at Valley Hospice. So I just wanted to give you just a little bit of information. We are a nonprofit hospice founded in 1985. And at that time, our CEO, I interviewed her one time, and I just, when she was retiring from here, I've been here 18 years, I should say that. I've been here since 2004. And as she was leaving us, I said, why did you start hospice? It was so hard back then. The Medicare benefit didn't start till around 83, and she just said, now she has a West Virginia accent. I'm allowed to imitate her with her blessing. She said, it was the right thing to do. Taking care of the dying was the right thing to do. So that's what we're founded on. Just the right thing to do is taking care of our community. We served more than 1,300 patients in 2021. We service the northern panhandle of West Virginia, the Hancock, Brooke, Ohio, and Marshall counties. And then we also serve counties on the Ohio side, Jefferson, Harrison, Belmont. So within our service area, 7-county service area, we have 2 care centers. One is located by this star in Steubenville, Ohio at Trinity Medical Center West. It's a 6-bed facility that we rent space there at Trinity, and we have a hospice facility. And then nestled down here in the hills of beautiful Oglebay is Liza's Place, and it's a 12-bed freestanding hospice care center. So that's just a little bit about our hospice organization before we lead into our discussion about palliative care. So let's talk about what is palliative care. Palliative care is a fairly new medical specialty that focuses on comfort and helps people feel better and cope with the stress of living with a serious illness. The palliative care team focuses on the same things that hospices focus on: relieving pain, other trouble symptoms, meeting the emotional, spiritual, and practical needs of patients. The difference between palliative care, one of the differences in hospice, is patients can still receive curative treatment while they're receiving palliative care. And when they're under the care of hospice, they can no longer pursue the curative treatments that are part of their plan of care. And we've talked about this. The overarching goal of palliative care is to improve the quality of life, not only of the patient, but of their family. This slide is something we use when we go out to speak to physicians, referral sources, families. And for those of you who aren't at all familiar with palliative care, we try to sum up and look at it along the continuum of illness. So if you start down here and you have somebody who has no illness in their life, and then they're diagnosed with, let's say COPD. It's a serious illness. So they're diagnosed with this illness, and then they start receiving their treatment. So right at this point, there are some palliative care programs that start their treatment at the very beginning of this serious illness. And as they receive the palliative care, comfort care, they can also receive anything that's considered curative care. And let's think about maybe a cancer patient also. A cancer patient has diagnosed with a stage 3 cancer. They are pursuing curative treatment, but they have all these symptoms right out of the gate. The nausea, the pain. And so palliative care can take care of them right beside while they're receiving the curative treatment. So along this trajectory, the COPD patient would receive palliative care with the goals of keeping them comfortable. And then as it's towards the very end stages of their illness, that's when palliative care bleeds right into hospice. Hospice patients have to have the 6-month prognosis that's certified by 2 physicians. That's a qualification for hospice. Palliative care does not have a stipulation on a life prognosis. You can receive it at the beginning of the diagnosis as long as there's symptoms and you're diagnosed with a serious illness, and you can receive it throughout the trajectory of the illness, clear up until the time that patients receive hospice. The types of palliative care are hospital-based, and some of you might be familiar in your parts of the state. You might have a hospital-based palliative care. Community-based, and that's what our particular palliative care is, or clinic-based palliative care. So tonight we're going to talk about the community-based palliative care model. So Caring Connections Palliative Care is that community-based model. And what that means is that our nurse practitioner visits our patients in the comfort of their own home. They complete an assessment, they look at all their medications, they look at their lifestyle, and they take all that into play as they develop their plan of care and communicate with their physician. So after they do their assessment, they look at the medications, they collaborate with the physician, they direct the entire team made up of a physician, a social worker, and a chaplain, and proactively recommend medications and non-pharmacological interventions to treat the symptoms and improve quality of life. So you might say, well, what is something non-pharmacological that's not a medication that might help somebody with COPD? And that's where the expertise of palliative care comes in, that symptom management, that intense symptom management. It's not just about how many medications we can add to your plan of care. It's also about, in conjunction with that, people with COPD, we teach them when somebody is having an episode of, shortness of breath, place a fan in the room. If you take a cool cloth and you rub it along the trigeminal nerve, it helps with the air hunger. There are all these things that, in combination with medication, patients actually need less medication when they combine these things that we teach them to improve their symptoms. And everything that we do is based on the patient's goals. So, the advanced care planning piece of this, I'm sure I hope many of you've heard of advanced care planning, developing your living will, choosing who your medical power of attorney is going to be. That's so important as part of this plan of care, because, when we teach new clinicians, I teach them to, when somebody's diagnosed and you're in there and you're treating their symptoms, you kind of look at it through a crystal ball, like what's going to happen next? What do we usually see in patients the next 1 month, 6 months, 1 year, and prepare their family with what's to be. And when you do that, it helps decrease a lot of the anxiety of the unknown. And that's how we prevent ER visits, unwanted hospitalizations, because we do all this proactive prep and with patients that are suffering with symptoms and don't know where else to turn when they're, just discharged from the hospital, but yet a week later they start feeling the same way they did right before they went in the hospital. And that's the beauty of palliative care, because we come to the patient's home and we look at everything that's going on in that home, the medications, the psychosocial environment, all that plays into how we treat their suffering. So you might ask, how do we collaborate with the patient's doctor? If our nurse practitioner is in there, so we get the call, the family says, I think my loved one could benefit from your program. They're in and out of the hospital, they have a serious illness, and I really think they could benefit. So that what happens from that moment is we say, we'll call, you give us your physician's number, we'll call them and we'll coordinate the visit. So the physician gives permission for us to go out and visit. And then after that assessment and visit, our nurse practitioner calls the physician and collaborates. And we're the eyes and the ears of the physician and their team in the home setting. So, what we know is when somebody leaves the hospital setting, I worked for home health prior to hospice. And we were always taught that those first 48 hours were most critical to get in there, because what happens? You're sent home from the hospital, the big pack of papers. And I cannot get over, when I was in the hospital, you got one sheet of paper that we told them exactly what medicines to take, what treatments, and we taught them, and here you go. When my parents left the hospital, every time I had a folder that was like a 1/2 inch thick, and I'm thinking, I'm a nurse trying to sift through all this. My parents would be lost if I wasn't just pointing out, this right here is what we need to do. So within that 24 to 48 hour period from being discharged from the hospital is the highest risk for medications to get confused, for things not getting picked up at the pharmacy because maybe there's some issues with resources. So that's what we do. We get in there and we make sure we connect the dots of everything they wanted to happen when they left the hospital to what's actually happening in the home. And another thing that in today's world, through COVID, pre-COVID, the complex healthcare system that these patients and families have to navigate is just very burdensome and creates a lot of confusion when there are multiple physicians, all the specialists involved, your primary care doctor, and there's nobody there to really help pull it all together and communicate with that main physician. That is one of the main benefits that we've seen, is to pull all these things together and help the patients understand, okay, now I have all this information, what's most important, what do we need to focus on to give you the best quality of life? And it's all surrounded by what that patient wants, because what Mr. Smith wants at an end stage of his COPD might be very different from what Mrs. Jones wants. So that nurse practitioner is an expert at having those goals of care conversations of, here's where we're at, here's what we're probably looking at for the next 6 months, 1 year, trajectory. Here's the proactive things that we have available. What do you want? What is important to you? And that question on every visit, when I teach new nurses, one of the first things they ask is, what's most important to you? What right now is in thinking about your care is most important, and everything revolves around that. So then let's talk a little bit about who is eligible for palliative care. in today's world with palliative care, I will say this, there are so many different versions of palliative care programs that if you've seen one palliative care program, you've seen one palliative care. So in the state of West Virginia, our nonprofit friends and hospices, we've come together, and I'll give you their names at the end of the presentation. We've come together to develop a more consistent message to the state about what is palliative care, what is available to you, how can this help you and your loved ones. So we've defined it as people diagnosed with a serious illness, and that could be something such as cancer, COPD, CHF, Parkinson's, anything that is considered a serious illness. We can talk about if palliative care would benefit you or your loved one. These patients are suffering. Sometimes it's pain, shortness of breath, anxiety, nausea, and sometimes the reason why we have the psychosocial support of a social worker and a chaplain, because not all pain is physical. The pain that people have with COPD, end-stage heart conditions, the anxiety and the restlessness, and sometimes just the dynamics of not having the resources. And they know when they leave the hospital, yes, they've given me 3 new medications, but I'm only going to be able to pay for 2 of those. So which 2 am I going to do? That's also suffering, and that's addressed in these conversations. So we talked about the illnesses that people might have when they come to palliative care, the symptoms. And the other trigger is somebody that has these frequent ER trips, unwanted hospitalizations, and they're kind of using the ER to manage their care. So they go to ER, they're hospitalized. They're supposed to follow up with their doctor, say in 2 weeks. They're too weak and sick to go, not sick enough to go to the hospital. And then what happens in another 2 weeks is they go back to the ER to really manage the care instead of being able to show up at the physician's office to receive that, that plan of care. Another trigger for patients that might be eligible for palliative care when we talk to physicians' offices, who are the patients and families that call the office and, you know, they maybe have been out of the hospital for a short period of time, but they're calling in and they need help with symptoms and management, but there's nothing really that they could do in the physician's office. There may be conversations and maybe some issues with compliance. Maybe they're not understanding of the disease process. Those are the patients that we can get in there and help. The other trigger would be when we talk to somebody about, you know, what's most important to you? When you look at your situation with your illness, what's affecting your quality of life? And if there are limitations on that, we set short goals to achieve whatever it is. You know, I used to be able to go out in my garden and pick my own tomatoes. Now I can't even get on the porch. Okay, that's a goal that we want to set, and how are we going to get there? So those are the small things that are really, really important to people's quality of life that we focus on and incorporate that into the plan of care. So why palliative care? In today's world of medicine and healthcare, why palliative care? There is this gap that for patients with serious illness, that when you leave the hospital setting and between that time when someone's eligible for hospice, that 6-month window, there's home health, and they could come in to help with symptoms and management, but home health is very short-lived, and their expertise is in acute care management and not always the serious illness, long-term management of that illness. So we have this gap of people that are seriously ill. They're going back into the ER in the hospitals, and that's not what they want as part of their care. They want to stay at home. They want to manage things differently. So a Gallup poll that was done stated that 9 out of 10 people wanted to die at home. They wanted to manage their illness at home. The reality of that, done by a study of Stanford School of Nurses, 60% of Americans die in hospitals, 20% in nursing homes, and 20% in homes. So the reality is, what people say they want to be at home in the comfort of their loved ones and have quality of life versus what's really happening is very different. So palliative care is the solution to how we proactively help people stay comfortable in their home setting. So next, I'd like to focus on a case study. This case study was actually a hospice patient, but we can look at the situation and I can define what it would look like if this patient had palliative care in addition to hospice care. So this lovely lady on the left was actually one of our clinical managers here at Valley Hospice, and we worked together. And this was her lovely mother, Connie. So Connie had end-stage heart and lung disease, and Janet and I worked very closely together. So I knew that her mother was in and out of the hospitals, that she was caught, like her brother was at least once a week calling and saying, I don't know what to do. I don't know whether to take mom back to the hospital. We just got out, like, you know, just all this stress weighing on her shoulders. So her and I talked about, you know, working for hospice, that her mom was probably eligible for hospice. And I will just say that Connie was a firecracker. So here's Connie, and she was in the hospital, and Janet was at her wit's end, and she said, Andrea, I know that she would benefit from it, but she's so stubborn, and you know the word hospice, you know what she's going to think, and I work there. So she said, will you come talk to her? And I said, of course I will. So I go to the bedside and talk to Connie, and of course she didn't want to talk anything about the H word, hospice. Nope, she didn't want to talk anything about that. So I'm thinking, and we're talking, and I said, okay, I asked that question, Connie, what is most important to you? And this was her statement. I want to stay out of the hospital. And I went, aha, that is what we are experts at. So let's just talk about this for a minute. And if we could make that happen, are you open to the idea of signing on to hospice? And she looked at me and she said, maybe. I said, okay. So we kept talking and, you know, talking through what her fears are, what her anxieties. And she said, okay, I'm going to sign up for hospice. So this graph shows the 6-month period prior to all these red dots, her signing up for hospice. This black line right here represents her signing up for hospice. So prior to that, she had 17 ER visits and 14 hospitalizations. And the reason we know that for sure is because Janet worked here and we got the records from her physician's office, because we were like, this is truly a case study that we need to talk about. So these red dots actually represent the ER visits and hospitalizations in this 6-month period prior to signing on to hospice. Now, here she is, she signs on for hospice. These 2 blue dots represent 2 hospitalizations in our care center. She wasn't even going into the hospital. She was at home and her symptoms were unmanaged. So we can bring people into our palliative care centers, the hospice care center that I talked about, manage their symptoms and get them right back home. So let's see, this was probably about 4 months here. So maybe about 3 months, she had an exacerbation, a flare up. And so we brought her in, got her right back home. So in these 8 months, she only had 1 other hospitalization right here at the end of her illness. And look at the difference between her life going in and out of the hospital compared to this other side of just 2 hospitalizations. So we succeeded in that goal of keeping her in the hospital. But in addition to that, here's what her life looked like prior to. On the 6 months before, loss of control, fear and anxiety, loss of time with her family and friends. She loved to go to mountaineer track and she loved going out with her family and friends. None of that was happening. The med changes caused a lot of financial burden, and they'd started on 1 medication. Cardiac medications were very expensive, and they'd put her on another one. And then she just spent a lot of money on the one she had to just dispose of. Inability to participate in those hobbies that she loved, being away from her beloved dog, Sadie. Every time she went in the hospital, the dog went into mourning, she went into mourning, and it was just horrible for both of them. Not being in her own home, and her children, Janet, who worked here, they were constantly needing to miss work, and were constantly stressed about, oh my gosh, what's going to happen today? Is she going to need to go in the hospital? You know, and all this anxiety. So that was her life before hospice. So once she was admitted to hospice, she had an increased sense of control over her circumstances and her illness. She had less fear and anxiety because we were talking to her about her symptoms and we had things proactively in place. She was able to help her grandchildren, attended college award ceremonies. She went out to Mountaineer and loved to play her slots, shopping, lunch. They had a huge Mother's Day celebration and surprise birthday party. And when I mentioned the birthday party, she had a identical twin sister who had the same kind of illness trajectory as she did. And they got to have a surprise birthday party for the twins. She had the financial assistance with the meds because under hospice care, everything that's related to those end stage illnesses are covered by the hospice. So we covered all those expensive meds, and we helped her with compliance by being in there and teaching her the benefits of being on these medications consistently. She had the increased support from her family and decreased stress. She got to spend time with her beloved dog, Sadie. Her children were at peace. As you can see, they were like, oh my gosh, like we have a plan. We know what's going to happen. And my favorite thing is, I'm going to go back to this slide here. So towards the end of her illness, her daughter, Janet, said to me, Mom wants to go one last time to Kansas to be with her extended family. They had a huge family. They went to Kansas every year, and they had this week-long celebration. And she said she wants to go. And I was like, yeah. She said, well, she can't go. And I said, why not? She looked at me and I said, okay, let's talk about this. So we knew all the meds she needed. We contacted a hospice out there. When people travel, we contact the hospice wherever they're going. We make an agreement. If they need anything while they're there, we have this written agreement that they can call that hospice and they will come meet their needs. So we put all this in place, and she made that trip. She made that trip to Kansas. And this hospitalization here represents, on the way home, Janet called me and said that was it. That trip was everything she needed to accomplish, and she's tired. And I said, okay. She said she wants to come back to the care center. So she drove right from the airport. Janet brought her to our care center, and she spent the last week of her life in the care center surrounded by hospice professionals and her family. And that's where she died after that trip. So I tell you this story to talk about the difference in quality life. And if we would have had palliative care at this time, we didn't have our palliative care program. We could have had palliative care in there these 6 months before, 1 year before, probably 2 years before, and really got her calmed down to where she would have had a much better quality of life than she did without palliative care. And here's some pictures. And I said today when I was practicing this presentation, I said to the person on the other end, I said, boy, she does not look like a hospice patient, does she? So this is Connie as a hospice patient, and this is her beloved granddaughter, Amanda, at her college award ceremony. She was so excited she got to go here. And this is Connie in Kansas. This is Connie with her granddaughter. This is Connie with her nephew when she made that last trip to Kansas as a hospice patient. So that's the end of my presentation. The last thing I'd like to share with you is these are our Hospice Friends of West Virginia, our nonprofit hospices that also offer this program. Hospice Care, Hospice of the Panhandle, Hospice of Huntington, and Hospice of Southern West Virginia, and then Valley Hospice. So if you live near any of these hospices, or you're aware of these hospices, and you know of people that might benefit from a program that we just discussed, I encourage you to have them call these hospices and ask about their palliative care programs and how they could help them during their illness. And the last slide is questions. I'm not sure how I did on time, Kevin, because I can't see my clock. I think I'm okay.
Yeah, you're good. You have plenty of time.
I'll stop that now and we can come back to our screen.
Okay. So if anybody has any questions, you can either put it in the chat, or you can unmute yourself and ask a question.
Any questions about hospice or palliative care? You're muted, KJ.
Sorry, I thought I had unmuted it when
Okay.
I turned my video back on. Sorry, thank you. Does one have to be in a serious enough illness that will be considered terminal at some point, it just isn't yet, to enter the palliative care, or?
That's a really good question. So the definition of serious illness, that's when I said you've seen one palliative care program, you've seen one palliative care. Some of them explain it as chronic illness. Some refer to it as serious illness. Some refer to it as life-limiting illness. And that's when we were like, how can we explain this to people in a way that they would understand who qualifies? So we landed on serious illness. So there does not have to be a physician saying, I give this patient 1 year, I give them 2 years. The serious illnesses that we talked about, COPD, CHF, once you're diagnosed with those illnesses, they're not curable. The trajectory, you could have periods of where you're doing well and then exacerbations where they're in the hospital, but there's nothing that's going to cure those conditions with their lungs or their heart for the most part. So cancer would be anybody like in stage 3, even some stage 2 cancers that are getting treatments, and the treatments are causing them suffering, and they need that support of that nurse practitioner in the home. So there isn't there aren't a lot of regulations and really defined, like hospice. Hospice, this physician has to certify 6 months or less, and another physician also certifies that. So that's really, cut and dry. Palliative care, and that's why I say if you called out to California, their programs might be in there right at the time of diagnosis, because they have a statewide program. They've been doing this for a long time. So right at the time of that CHF diagnosis, COPD, they may connect them up with a palliative care program. If you talk to most of the hospices in West Virginia, we're more probably in those end stage windows. But as far as giving you a time frame of 1, 2, 3 years, I would just say that when the physician says they're in the end stages of their COPD, or they're in a state where they're not eligible for hospice, but they have these serious illnesses and they're suffering. There's some type of suffering going on and symptom that's still unmanaged. Those are the people to call your hospices and just ask. All of us, we take calls and we listen to what's going on. And if we're not sure, we go out and visit. We go out and visit, we have more conversations with the physician. But the main thing is we want people to know that there is a program available to you, and we'll talk you through if it's something that we feel that you're eligible. We'll connect with your physician if we feel that's a possibility. Does that make sense?
Yeah, that helps. And I gather that other hospices have different definitions for their palliative care program.
So we're really working hard just over the last couple of months. Those hospices that I mentioned on the screen, we're just in the process of defining, this is what we're calling serious illness, chronic illness. We Valley Hospice have landed really solidly on serious illness, and we're still coming together saying they're providing the same service, but in their literature, it might say chronic illness or life-limiting, but we're all providing the same program. Those programs that I mentioned, some of them have been doing this for quite some time, and they have a large program. So they have a lot of resources, and they're very already seasoned at what they do, and their programs have been around for a while.
Okay. Would a program like yours be appropriate for someone? For example, a few years ago, my mother fell, fractured right shoulder, left pubis, spent 3 months in a nursing home and came home. Obviously, she was quite limited still for, a good while after that, although her prognosis was quite good. Would that program at that time have been something that would have been available to her to have assistance in the home, or would that not have qualified?
That's a good question. So I should have mentioned that chronic pain, if pain is the only diagnosis that is presented to the hospice for palliative care, that alone, without an underlying cancer diagnosis or other diagnosis connected to the pain, is not something that palliative care is able to manage, just chronic pain.
Mhm.
So in that situation, it sounds
Okay.
like without knowing if she had other, complex medical needs, that if it was for pain management, that wouldn't fall under the palliative care umbrella. That's probably the
It
the one
would not,
exception.
you
It would
said.
not.
Would not.
Um,
Okay, okay, yeah. Yeah, and I just, again, I'm just curious, just was wondering. We did have some home health for her for a while,
Yes.
still doing some home health physical therapy and stuff. So it was more than just the pain. It was, the inability to move around as much as she was accustomed to, and using a walker and things like that. Assistance in and out of the shower. So again, just curious, it was just a thought that came to me.
Yeah, that's a really good question. And I was going to say home health in those situations, because they can provide the therapy,
Mhm.
is the right fit for that situation. Now say that home health
Mhm.
was in there, physical therapy was in there, and then, she continued to decline, and maybe she wasn't eating and more weak, and the goals of care really weren't defined. You didn't have that medical power of attorney. You didn't have a living will. That is something that if that was brought to the attention of the physician and there was complex needs, that the nurse practitioner could come in there and talk about those goals of care and develop those living wills, medical power of attorneys. We wouldn't be in there that long, because that usually is done between 2 and 3 visits,
Okay,
but it is something that she might have benefited from and qualified for a palliative care.
okay,
Good questions.
thanks. Thank you for your answers. Appreciate it.
And I would encourage, if you know anybody that you think might qualify, encourage them to call their hospice and just find out, just ask about the program, and we can send a nurse out, and do the investigation work for them. Because some people just wait because they feel like, oh, it's not the right time or it's not the right thing. And I always encourage people, just call and ask, and we'll answer all your questions and do the legwork if we need to get in touch with the physician and help you understand if you qualify.
Okay. You mentioned people in like stage 2 cancer might qualify. And that would be even though their treatment is expected to bring about a cure. Is that
Yes,
accurate?
that's a really good question.
Okay.
Yes. Some people with stage 2 cancer, their response to their treatments, they're just really ill. And if if their age is up there and they're just not tolerating the treatment, but they're still going for cure, absolutely. And those are the patients that we really can improve their quality of life. And, they're saying, wow, I'm so sick. I feel like, yeah, I'm doing this treatment, but I'm not living. And then we come in with the combination of oncologists. Okay, what symptom can we help you with that's going to give you that quality of life while you're pursuing your cure? Yeah, that was a really good question.
Okay. All right. Well, again, thank you so much for the answer.
Welcome.
Appreciate it. Mhm. And not sure where Kevin has disappeared to, but and I'm not sure that he actually mentioned in his introduction of you, he also is a member of the West Virginia Wellness Board. And that's how he ended up recruiting you to do this particular presentation tonight. Thank you very much for doing that. Again, I'm not sure where he's gone off to, but I, as another representative of the board of directors for West Virginia Wellness, let me offer my official thank you again for doing this. We really appreciate it. For those of you listening, this presentation has been recorded and it will be available there will be a link available to view it from the West Virginia Wellness Facebook page in probably about 48 hours or so. Jennifer's usually pretty good about getting them up fairly quickly. So anybody else have any questions for Andrea?
I might say something. My name's Lorraine Pounds. I'm from actually Boulder, Colorado, but Marnie Rebin told me of this webinar, this meeting today. I thought she might be here, and she's part of the West Virginia Wellness
Yes, she
group.
is.
And and we're aromatherapy colleagues. And
Oh,
my
nice.
I'm a retired nurse and a retired hospice nurse, and also was very involved with palliative care. So this is a hot topic for me, and I really appreciate all you said. And you have a wonderful program, and it's amazing how many counties you're serving. I developed an aromatherapy program for our county hospice some years ago, and wondered if you've been able to integrate any aromatherapy, palliative care interventions.
Oh, that's a great question.
It takes a
Yeah.
budget. It takes trained
Well,
practitioners.
Lorraine, you'd be very proud of our program. We trained all of our patient care aides and all of our staff, even our social workers and our chaplains, on aromatherapy. They all have a little bag
Wonderful.
with their oils. We use doTERRA. So they all have a little bag with their oils. We met with a specialist and we developed, there's 4 or 5 different scents that, one for uplifting, one for, the main symptoms that we experience. And then they taught us how to combine them at, if we needed to do that. I can't think of the names of them right off my top of my head, but so they're trained, and then they have a little card in their bag that teaches them the hand massage and the trigger points, the pressure points,
Wonderful.
how to do that. And I'll tell you a little story. We had a friend of mine who her husband was young and had dementia, and she cared for him like 3 years. And she said, Andrea, I can't sleep. I'm a mess. I said, tell me about it. Are you taking anything now? And I said, you know what? Have you ever tried aromatherapy? She said, no. And I said, you know what? And I talked to her about lavender, and I talked to her about different scents. And the next day she told me that she slept all night and how wonderful. And so there's an example, and I'm glad you mentioned it, because now I'm going to put it in my presentation. That's an example of non-pharmacological interventions that instead of taking a sleeping pill, I just said, try a little lavender, try a little lavender, put your diffuser on at night, try these scents. And that has been such a wonderful, we train our volunteers. So if they're going into nursing homes, we train them on we focus on the hand massage. And so for this particular wife, I talked to the aide about, when you go in there to give him his bath, before you leave, say to her, I would love to give you an aromatherapy hand massage. So they're trained, like when you go and get your manicure, our patient care aides are trained for even the family members and oh my gosh, so we practice on each other, And so she said, oh my gosh, that was just like I was going to the spa, like she was there for him. But before she left, she always said, can I give you one of my, the aromatherapy hand massages? And it uplifted her. It brought her comfort. So yeah, thank you for bringing that up. I'm going to make sure I add that to the presentation.
Yeah. The program I developed for our hospice also was largely home visitation, and the aides were trained in providing the products that we'd worked up. And it's also noteworthy how much it helps the family when you bring them into the home and leave them at the bedside and let them know how to use them and so on. And for some, they really enjoy exploring, other things they can do with aromatherapy. And it really is uplifting and helps the stress, skin care, respiratory care. It helps so much. So it's wonderful that you have that. My program, the program I developed, came to an end when some funding issues shifted, and they weren't getting reimbursement as much as they had through Medicare, and they actually stopped the program for financial reasons.
Oh, that's sad.
But kudos to you for having that as part of your plan of care, because it really does help on so many different levels.
Yes, I'm so glad. So I don't forget when we're done here, I'm going to plop it in there so I don't forget before I present again. Thank you.
Fine. Yeah, thank you.
Great question.
Yeah, I think that would be a great idea, Andrea, to include that the palliative care is not just for the patient, but you can also do some care for the caregiver as well.
Yes.
And do you know, for some hospices, including aromatherapy in your plan of care is a marketing tool.
Mhm.
I don't know in your neck of the woods, but here and in other places for hospices to advertise or promote that they use aromatherapy and other palliative care measures, it's a marketing item.
Absolutely. It's such a differentiator. We have this umbrella, it's called Meaningful Moments. It's all the things that aren't covered by Medicare. Aromatherapy, pet therapy, the automatic pets therapy, if you've seen that on advertised. There's a veterans program, so they're not funded by Medicare. So we, like you say, we market that. We have a golf scramble. It's called the VH Cares program. So people, when we have these fundraisers, they know that they're fundraising for the things that Medicare doesn't cover. And they are thrilled to participate when we talk about these type of things. So yes, the funding, we've got creative about, okay, we tell the stories of how it benefits. And, you know, I'm there selling the 50-50 and, you know, and stuff, and you can tell these stories. And it's just a great connection with the community because they think of hospice of dying. And I'm there talking about, hey, listen, like, you know, with this veterans program, we were able to do this. And it's a great, like you say, way to differentiate your program and bring hospice into the community.
Right. Thank
We
you
could
for your
probably talk all day,
presentation.
Lorraine.
It was really wonderful presentation.
Oh,
Thank you for your summary. It was really quite good.
Thank you. You have a wonderful, this is a great idea, this venue and how you're coming together virtually. It's a great concept.
Well, we were kind of forced into it like everybody else, you know, instead of doing a live get together like we had done for a couple of years. But the silver lining to it has been that we are able to reach people on the other side of the country, like Lorraine. And we have had presenters from San Diego and Washington State and, you know, people tuning in for programs from all over the country. So it has really helped to expand our reach, and we appreciate that. Are there any other questions or comments for Andrea this evening from anybody?
Andrea, this is Beth. I did have a wonder about how COVID may have impacted services of your program over the last couple of years.
That's a great question. So we launched this program right when January. And then we had our highest number of referrals. We had our marketer out there doing a great job. And then COVID hit in March. And then, you know, our marketer couldn't go out. So we hadn't educated our community yet. We just started in here. We're the first movers. Nobody has done this before. So we kind of got shut down because we couldn't get to our providers. They were just consumed like we were with COVID. So the referrals trickled in. And we're just now starting to regain our momentum and get more referrals. But it truly just stopped our momentum because, you know, you all know everything was about COVID, all energy, all focus, all resources. So, you know, to go to somebody and say, you know, this is the type of patient, they were just so overwhelmed with COVID. They're like, you know, we can't take on anything new right now. We don't, you know. So it was a real challenge. And most of our referrals came from truly like family and friends of us here at hospice. We knew people in our lives. We knew people at my church. Once people knew that we were doing this, I would just get texts from people from church like, hey, do you think? I'm like, yes. Yeah. So, you know, the referrals really generated from internally. And now we're just starting to see our marketer is starting to get back out there and explain the program. So yeah, it was a great question. It pretty much just shut it down. Just because our community didn't know about it. Now the other hospices, their programs are big because they were already established pre-COVID. So they weren't starting ground zero with their education. Good question.
Well, thanks for your services and for hanging in there. Glad you're back up and running.
Thank you.
All righty. Well, once again, thank you everybody for joining in this evening. We certainly appreciate it. Andrea, we definitely appreciate you for jumping in here and doing this evening.
My
And
pleasure.
I think everybody learned something from it. And we will look forward to reviewing the recording again sometime. And perhaps we'll have you back another time to do another program for us.
I would love that. Thank you so much.
Ready. Thank you. And everybody have a great evening.
Have a good evening.
Thank you,
Thank you.
Andrea.
Night, guys.
Bye-bye.
Bye-bye.